Hello.
Hello, good evening, sir.
Am I audible?
Yes, sir.
Sound is silent about. Good evening, sir. I'm Dr.
Good evening.
JEMIMA EVANGELINE from Southern Railway Hospital, sir.
Yeah.
I'm going to present about acromegaly cases posted for transphenol surgery, sir. Shall I start, sir?
Pituitary adenoma. Okay.
Yes, sir. A 28-year-old male got admitted with chief complaints of headache for two months. History of presenting illness. Patient was apparently normal 2 months back. He has complaints of headache, which is incidence in onset, gradual in progression. No history of visual disturbances. No history of vomiting. No history of seizure. No history of excess tiredness. Past history. No history of diabetic or hypertension. No history of ischemic heart disease. No history of previous surgery. No history of any drug allergy. No history of previous hospitalization. Personal history: non-smoker, non-alcoholic, normal bowel and bladder habits. Family history: no history of similar illness in family members. General examination: patient conscious oriented, well built, large extremities, afebrile, no pallor, no cyanosis, no clubbing, no pedal edema, no generalis lymphadenopathy. Vitals: pulse rate 76 per minute, regular in rhythm, normal in volume, felt equally in all peripheral vessels, no radiofemoral delay. BP 110/70 mmHg, taken in left upper limb in sitting position. Pulse rate 78 per minute, regular in type. Airway examination: mouth opening normal, multiple grade 3, enlarged face present, temporum and multiple distance normal, neck movements normal, teeth normal. Systemic examination: respiratory system, normal vesicular breath sounds, bilateral air entry equal, no added sounds. Cardiovascular examination: S1 S2 heard, no murmurs. Abdomen soft, no organomegaly. CNS: higher mental functions normal, no focal neurological deficit, no cranial nerve involvements. Provisional diagnosis: a 28-year-old male diagnosed to have acromegaly, posted for transphenodal resection of pituitary adenoma. Our
Okay.
anesthetic.
Now, 1 second. In this examination, you said this is already diagnosis given. You said mandible is. Did you describe anything about the mandible?
No enlarged mandible, sir.
No enlarged mandible.
Yes.
Right? The word enlargement is not the correct description. Elongated mandible.
No elongated.
Mandible
Okay,
looks
sir.
longer than that. Then only
Okay,
you can
sir.
call it as acromegaly. Without that, how can it be called as acromegaly? Okay, one of the classical features of acromegaly is elongated mandible.
Okay, sir. Okay, sir.
So when you, even though this is a very, we are just assuming that this patient is acromegaly patient. We are not examining a real patient. So
Okay, sir.
the description should match the clinical condition. Okay.
Okay, sir. Okay, sir.
Now, what is the condition called if it is happening in a child? Acromegaly, does it happen in a child or in an adult?
Adult, sir.
Adult. So adult description of what is the reason for this elongation of mandible and the enlargement of the hand?
Excess production of growth hormones.
Growth hormone. Growth hormone comes under what category of the pituitary hormone? What type of cells produce growth hormone? What are the various cells that produce hormones in the pituitary? It's called somatotropic hormone. Have you heard of
Yes, sir.
that term?
Yes, sir.
Comes under growth hormone, comes under somatotropic hormone. And
Okay,
if it
sir.
happens at the very young age as a child, what will happen to the child?
It is called
Huh?
cretinism, sir. Cretinism.
Cretinism is a thyroid. Underdevelopment of thyroid is called cretinism. Here the child becomes huge, grows very
Okay.
big. What is that
Okay,
called?
sir.
More bigger than for the age, height as well as weight. It's called
Gigantism, sir.
gigantism. Gigantism. Okay.
Okay, sir.
So if it exhibits in the adult life, it is called acromegaly. If it exhibits in the childhood itself, it is called gigantism. Okay? And it comes
Okay,
under, it's produced by somatotrophs in the pituitary. Okay.
Okay, sir.
All right. Now you go ahead with the management.
Our anesthetic challenges are airway difficulties, obstructive sleep apnea, associated endocrine disorders, and theater positioning, rapid and smooth emergencies. First, we will confirm it with the investigations, with which include basic blood routines, complete blood counts, RFT, calcium, basal prolactin, blood glucose value in fasting, and serum uh, serum cortisols, thyroid functions test, thyroid profile, echo ECG. If a patient is planned for surgery, we can do MRI and insulin growth factors and spirometry. Treatment options are medical therapy, surgical therapy, radiotherapy. Medical therapy includes somatostatin analog like octreotide, lanreotide, dopamine agonist like bromocriptine, cabergoline, growth hormone antagonist like pegvisomant. Surgical decompressions include transphenol surgery and transcranial approach. Last option is radiotherapy. Um, Anesthesia plans including if we anticipated difficult intubation, we can use awake orotracheal hyperaptic intubation. We should include throat pack also. For injection, we can add antibiotics, IV hydrocortisone, and we use short-acting opiates like remifentanil for rapid and smooth emergence. Um, uh, we have to rule out increase intracranial tensions.
This point has to be told at the beginning itself. This is coming at a very late stage. Okay. One of the
Okay,
important things you have to say in the beginning of the presentation itself is raised intracranial pressure and how to manage it. All neurosurgical cases, that is one of the very important things that has to be talked at the very beginning of the discussion.
Okay, sir.
So, what is the harm if you allow the intracranial pressure to? What is the normal intracranial pressure?
8 to 20 mmHg, 15 mmHg.
15, maximum 15. Okay.
15. Yes,
So,
sir.
what will happen if it increases this intracranial pressure?
It will cause
Right.
visual disturbances,
Visual
seizures.
disturbance, is it because of intracranial pressure rise? Everybody having a, you said patient is complaining of headache all the time, isn't it? In your history, you said patient complains, has come to the hospital, complains of headache, persistent headache.
Okay,
Isn't
sir.
it?
Yes,
So,
sir.
can headache be caused by raised intracranial pressure?
Yes, sir. Yes.
Yes. What is the mechanism? Why does it cause headache?
Cerebral vasoconstriction.
Cerebral vasoconstriction. When vasoconstriction cause headache or vasodilatation cause headache?
Sorry, sir. Vasodilatation cause headache.
So the vasodilatation, the cause of headache in raised intracranial pressure. See, in an adult, the skull is a rigid compartment or a rigid box, isn't it? And
Okay, sir.
inside the soft tissue brain is there, there is water, I mean CSF, which is liquid, and there is blood. These are the three components inside the cranial cavity. So what is the reason for the rise in intracranial pressure? If there is a pituitary tumor. Is
Okay.
pituitary exposed outside along with the other brain tissue, or is it kept secretly or safely in another part of the skull?
Okay, sir.
It's kept inside the pituitary fossa.
Pituitary fossa, otherwise called as
Sella turcica, sir.
sella turcica. Very good. So it is normally does not cause any rise in intracranial pressure because it is confined inside a small box-like portion of the skull. But once this tumor grows bigger, then it will start bulging out of that small box and start exerting the pressure onto the brain tissue above that, because the pituitary is at the bottom portion of the brain. All of you know, if you remember your anatomy, there is a stalk and there is a, it is like a small early growing fruit or a part of a fruit in a tree. Okay? It is like a stalk with a bulge in the inside, and that will cause a rise in intracranial pressure. And when the intracranial pressure rises, will there be any pressure on the brain tissue?
Yes, sir. It will
Yes.
cause
So
pressure.
the brain tissue pressure, where it will be transmitted?
Optic chiasma.
Dural sinuses.
The meninges. All the meninges will be stretched, and the pressure is transmitted to the brain tissue. There are coverings, isn't it? Pia, arachnoid, and dura mater. Coverings are called the meninges. These meninges will be stretched. Imagine you have a polythene bag and you put a lot of water inside and then squeeze the bag. What will happen? The polythene cover will stretch. Similarly, the meninges will start stretching, and these meninges are having a lot of innervation, sensory innervation. So the stretching only causes the pain. That is the mechanism of constant pain because of the stretching of a meninges covering the brain tissue, being stretched by the pressure inside the cranial cavity, getting increased more than normal. Okay? So if the pressure continues without reducing and goes on increasing, what is the danger? Why you are always worried about? Are we worried about the headache because of the raised ICP, or something else more dangerous can happen to the patient?
Coning, sir.
Coning, yeah, or uncal herniations. Coning is the most dangerous of all the complications, but the brain tissue can bulge through small gaps that are present between the coverings. Okay, that is called herniation of the brain. It can occur in several locations. When you read about the CSF and hydrocephalus, this is a common question the examiners will ask you. What are all the locations where the brain tissue can herniate? Any idea? They are called tonsillar herniation, uncal herniation, and conal herniation. These are the three important locations where between these separating layers, the brain tissue can get itself pushed, which is called the herniation. Of that, the medullary coning or herniation is the most dangerous one because that is the largest hole through which the pressure can be transmitted, and the structure that is passing through that is the lower portion of the medulla and the starting of the spinal cord. And as you all know, the lower portion of the medulla contains all the vital centers like the vasomotor center, respiratory center. They are all present at the medullary area. And once that tissue is pushed through the foramen magnum, which is the opening in the skull, there will be a lot of compression, and these centers will get crushed and go into lack of blood supply or hypoxia, and that is how the cardiorespiratory arrest can happen in coning. Okay? It is a very important point that we have to keep in mind. So any neurosurgical procedure where there is a possibility of raised intracranial pressure, we must plan for maintaining the pressure at the normal and plan our management in such a way that we will decrease this pressure by some other adaptations so that this dangerous complication of coning does not happen. Okay. So what are the methods of managing the raised intracranial pressure?
Lumbar drain.
Lumbar drain, straight away lumbar drain. Just like managing hypoxemia in one lung ventilation, this is a very common question that will be asked if you get a neurosurgery case. Even hydrocephalus, they can ask you this question. Okay, how to manage a raised ICP and prevent abnormal increases in the intracranial pressure. One, head up tilt. Can head up tilt help?
Yes, sir. Drainage
How
will be
does
better.
it will be helping the venous drainage by gravity. Okay, that will reduce the fluid drainage also, and that will first and foremost is head up tilt. Can ventilation help in some way?
Yes, sir. Hyperventilation.
Hyperventilation. What is, how long you can hyperventilate? What is the maximum level you can reduce the CO2? What is the difference between hypopnea and hyperventilation? Dr. Satya Priyan is also there. I think he's a very silent spectator. Are you there, Dr. Satya Priyan? Yes.
He's inside the theater, sir. He's having a case after this. Still,
Okay.
we over in 5 minutes, sir.
Right. Okay. Shivasankari, you are joined. Thank you. What is the difference between hypopnea and hyperventilation? Hiranmayi?
Sir, hyperventilation is the respiratory rate is more than the normal. That is hyperventilation.
Hyperventilation is increasing rate and depth of ventilation,
Yes, sir.
resulting in CO2 washout or decrease in CO2. Then only you should call it as hyperventilation.
Sir.
Hyperventilation is increase not only in rate but also in depth, which results in decrease of CO2, then it is called hyperventilation. That can be done by the patient voluntarily when they have anxiety, when they have fear, and we can iatrogenically produce during our mechanical ventilation by increasing the rate and tidal volume. This is one of the temporary methods, whereas hypopnea is increase in depth of ventilation where CO2 is normal. Okay. Tachypnea is only increase in rate. Okay. Eupnea is normal ventilation. Bradypnea is decrease in the rate of ventilation. Okay. So these are all some of the terminologies which sometimes the examiners may suddenly ask you. So whenever you say patient is hyperventilating or I am hyperventilating the patient under mechanical ventilation, it should result in a decrease in the CO2. Blood arterial CO2 level should decrease. So this is the patient in acidosis will hyperventilate. He will not only increase the rate but also depth and try to wash out the carbon dioxide to compensate for the metabolic acidosis that is happening. That is one of the compensatory mechanisms. So similarly, earlier days in neurosurgery, apart from head up tilt, we always plan for a bit of hyperventilation where we try to maintain the CO2 between 30 and 35 millimeters of mercury. What is the normal value, Dr. JEMIMA, for CO2, arterial CO2?
30 to 45. 35 to
35 to 45 millimeters. 35 to 45 millimeters of mercury is the normal range of arterial PCO2. So by decreasing between 30 to 35, what do we achieve by this hyperventilation?
CO2 is a vasodilator in the cerebral circulation, sir.
Very good.
So by reducing CO2, we reduce the vasodilatation effect, so lesser secretion of fluid into the interstitial space.
CSF formation will be there. It causes amount of vasoconstriction. Okay, but prolonged vasoconstriction, what is the danger?
Decreased blood flow.
Decrease the blood flow and ischemia will result. Okay, so that is why beyond 30 minutes we are not supposed to hyperventilate and reduce the CO2 level in the blood. Okay, that is a very important thing. Earlier days, neurosurgery, when they are performing neurosurgery, neuroanesthetists used to hyperventilate purposely for several hours. But later they found that this drastically reduces the ICP, but also reduces the blood supply to the brain, and postoperative neurological deficits have increased because of the ischemia that has been caused by this hyperventilation. So the current guideline is not to hyperventilate and decrease the CO2 less than 30, number one, and maintaining the PCO2 between 30 to 35 should not exceed more than 30 minutes to reduce the ICP to a particular level. Okay, so these are the this is the second method. Third method, any other technique you can think of to reduce the ICP?
IV
Anti-edema.
diuretics.
We can give diuretics. What type of diuretics we can give?
Osmotic diuretics.
Osmotics and
Osmotic
mannitol
diuretics.
can give.
What is the
Mannitol.
danger of osmotic diuretic? Or yeah, and immediately they will may reduce, but what is the ultimate effect?
Pulmonary edema.
Pulmonary edema, if the cardiac problem is there, you are right. If the cardiac load, the heart is not functioning well, there will be first absorption of fluid from the interstitium into the vascular compartment by the osmotic diuretic. This may cause an increase in the preload to the heart, so heart may fail. So we cannot use osmotic diuretic like mannitol in patients with congestive failure. But if a patient has a normal heart, we use mannitol. Is there any risk or any bad effect after the effect of the mannitol goes off? There will be rebound edema, okay, because this is a very short-acting drug. Immediately it will bring down the ICP by drawing the fluid from the interstitial spaces of the brain tissue. But once the effect of mannitol, which is hardly about for 1 to 2 hours, the fluid will again seep out and there will be a much more increase in the fluid volume and edema will happen in that area. So long-term effect is not good. So in order to avoid this, what other type of diuretic you can use? What is the regular diuretic you will give in case you want to reduce the volume?
Lasix.
Furosemide or Lasix. Okay. Why it is called Lasix?
It lasts for 6 hours, sir.
Action lasts for 6 hours. Okay, that is the reason why they named it as the Lasix. But what is the other drawback of Lasix?
Hypokalemia.
It can cause electrolyte imbalance. It will not only wash out water, but also it will wash out the electrolytes, prevent the absorption, and so you will have hyponatremia and hypokalemia. So that is the long-term demerit of Lasix. Okay, but to tide over an emergency increase in ICP, we have to resort to Lasix administration. Anything else? So we have seen head up tilt. We have seen temporary short-term hyperventilation. Third, we have seen usage of diuretics, either osmotic or diuretics like loop diuretics like Lasix. Then fourth,
3% hypertonic normal saline sodium chloride.
hypertonic normal saline. Okay. So that also is more or less like your diuretic. Then anything else?
Ventricular drain.
Steroids.
Huh?
Ventricular drain.
Steroid.
Drains.
Ventricular drain. That is in hydrocephalus, you can do a ventricular drain. But before drain,
Steroids.
lumbar drain or ventricular drain of mechanically removing the CSF. Any other drug, pharmacologically, can any other drug help in reducing the ICP?
Steroids.
Steroids. What type of steroids? All steroids?
Hydrocortisone.
Dexamethasone or betamethasone. Okay. So people
Dexamethasone.
usually put the patient on decadron or dexamethasone as 8 to 16 mg per day. Is another method of reducing that. How does it help? How does this dexamethasone help in controlling the ICP? What is its mode of action? Which location does it act when you administer dexamethasone? It strengthens the blood-brain barrier. Okay. So normally when the ICP increases, there is a disruption in the functioning of blood-brain barrier. That is stabilized by your administration of dexamethasone or betamethasone more than your prednisolone or hydrocortisone, which are all long-acting drugs. I mean, which are all drugs which do not have this much of effect like dexamethasone or betamethasone. Okay. So what is blood-brain barrier? What are the components of blood-brain barrier? In neuroanesthesia, these are all common questions. Even if the case of hydrocephalus is kept, you can expect these are the standard questions that will be asked. Blood-brain barrier. The word itself is self-explanatory. So there should be a vascular component. There should be a central nervous system or neural component, and in between those two, there should be something. So just like your kidney, where you have the Bowman's capsule, filtering unit, what are all the structures you have there? Always remember some analogy so that you can easily remember things. Okay. In kidney, the glomeruli, what are all the layers through which the fluid has to be filtered?
Basement membrane.
Straight away, basement membrane.
Sir, capillary endothelium,
Basement membrane,
processes,
Afferent.
astrocyte food processes, pericytes, and basement membrane.
Basement membrane is between the astrocyte and the capillary endothelium. Okay, so that is where the basement membrane comes in. The basement membrane is not beyond the astrocytes and podocytes. Okay, so there is a projection of the neural tissue. There is a vascular component on one side. In between, there is a membrane. That is the basement membrane. Okay, just like in your Bowman's capsule, you have the afferent and efferent capillaries. The endothelium is there. Then there is a basement membrane. Then there is a proximal nephron food process is there. Similarly, the same arrangement, three structures are here, and this is the one which allows the fluid as well as other solutes to transmit from one area to other, from the blood to the brain and brain to the blood. Whenever the ICP rises or there is a tumor inside the brain, this blood-brain barrier integrity is affected. And dexamethasone or betamethasone is supposed to stabilize this blood-brain barrier so that there are fluid excess does not happen inside the neural compartment and increase the ICP. Okay. And lastly, you can mechanically remove the CSF either by ventriculostomy in cases of hydrocephalus or lumbar drain in cases of acromegaly or adenoma excision, or even for your tumor excisions in the skull, transcranial excision of meningioma or glioma, astrocytoma, whatever type of tumor you want to excise, you can keep a lumbar drain and try to remove the CSF. So these 5 points you have to remember. One is the head up position. Second is the hyperventilation for a short period. Third is diuretics, both mannitol as well as Lasix. Fourth is dexamethasone or betamethasone. And fifth is CSF removal either by ventriculostomy or lumbar drain. Okay. So these 5
Okay.
things are expected out of you to answer for management of ICP in neuroanesthesia. Okay. Right. So you said these patients may have difficulty in intubation. What is the reason for the difficulty in intubation?
Most of the patients have
What will be the Mallampati score like? Will they have an abnormal 3 or 4 grade Mallampati, or they can have 1 or 2 grade in Mallampati also?
they can have 2 grades, sir.
Even
They
though
have
Mallam may
macroglossal.
be, Mallampati is here deceptively very
Deceptively, it
encouraging.
will
Okay, it will
encourage.
look like it is a grade 1 or grade 2 Mallampati score, but when you try to put the scope, you will not be able to see the larynx properly. So this
Yes,
is
sir.
one condition where Mallampati score will be fallacious. You cannot depend on that.
Okay.
The reason for that is excessive growth of the soft tissues in and around the pharynx, okay, which is very difficult to push and visualize the larynx.
Yes, sir.
And the patient sometimes have a very narrow opening where you will not be able to intubate with a normal size 8 or 8.5 for an adult male and require a smaller size. Is there any reason for that in acromegaly patients?
Enlarged arytenoid fold.
So the glottic opening may be narrowed, number 1, or down the trachea. Can there be any compression at the lower down in the trachea?
Yes, sir.
What is
There
it?
will be tracheal compressions in some patients.
Why?
Pressure some thyroid.
Very good. Thyroid enlargement may be present in these patients along with the regular abnormality of the growth hormone. Some patients have increased TSH production, which results in thyroid enlargement, which may be retrosternal and down the trachea, causing compression, which may require a smaller size tube for intubation. Supposing a patient with acromegaly has a stridor, when you examine, what does it mean? Can they have a stridor sometimes?
Yes, sir. Airway obstruction. Obstructive airway is there.
That can be obstructive, or is it due to cause of any other problem? When will you get a stridor?
Involvement of cranial nerves.
Cranial nerve or nerves to the larynx?
Vocal cord.
Laryngeal
Vocal cord involvement because of laryngeal nerve palsies. Okay, that is the one of the reasons infiltration into the laryngeal nerve producing any type of palsy can happen. Okay, so that is another thing which can happen with the airway. And OSA may be present as part of this anatomical changes that happen in acromegaly, which produces OSA because the pharyngeal structures collapse. And that is another important thing. So how do you treat an OSA?
Breathing exercise and CPAP. Adequate
CPAP or BiPAP has to be applied in the conservative method of opening up the airway, especially when the patient goes to sleep and the muscle tone decreases, the pharyngeal muscles collapse, and that is how the obstruction occurs. And that can be relieved by asking the patient to wear a tight fitting mask through sleep while the sleeping is happening. And usage of CPAP or BiPAP will help in opening up this collapsed airway and help in the relief of this obstruction. And you said we'll have to estimate the cortisol. Why do you want to estimate the cortisol level, serum cortisol?
To rule out Cushing disease.
Sometimes, there may be not only one
Associated
hyperactivity of the hormonal secretion, but there may be
functional.
multiple hormonal hyperactivity, one of which may be in the form of Cushing's disease, which is a increased secretion of ACTH resulting in increased cortisol production. Okay, so that is the reason why you have to check the serum levels of prolactin is the most common hypersecretion that happens in pituitary adenomas, and the other things are we have to think of doing the estimation of other hormones which are produced, stimulated by the anterior pituitary and posterior pituitary. Why posterior pituitary is not commonly involved in this? Whatever we talk about, we are talking about all the hormones produced by the anterior pituitary. Can posterior pituitary hormone, what are the hormones produced by posterior pituitary?
Oxytocin, vasopressin.
Vasopressin is also known as
Antidiuretic hormone.
Antidiuretic hormone. Very good. So where is it secreted or produced? Antidiuretic hormone. Is it produced directly from the posterior pituitary?
No, sir.
What is the function of antidiuretic hormone?
Sodium retention.
Water retention.
Water retention. Sodium
Water
retention.
retention.
Maintenance of osmolality of the blood. Okay, one simple word. The correct answer for that is it is a sensor to maintain the osmolality. What is the normal osmolality of your plasma or your blood?
280 million.
280 to 290. Always there is a range. It is not the fixed value of 280. Okay, you can have 280 to 290 milliosmoles is the osmolality. So if the osmolality becomes lower, what does it mean? If the osmolality becomes higher, what does it mean? If it becomes 250, what does it mean? If it becomes 300, what does it mean?
Hyperosmolality. More than 300 means hyperosmolality. Less than 280 means hyperosmolality.
No, what do you infer by that? When this value increases from or decreases from the normal range, what is the inference you get? You can call it hyper or hypo because of the value, but what is the ultimate inference you get by understanding that it is hyper or hypo? What happens to the fluid status in the body? You get more fluids and less electrolytes or solutes, or you get more
Hyperosmolar. Sir,
water content decreases or
less fluid
increases.
and more. Hyperosmolarity, less fluid, sir. More of electrons.
You are losing water, it becomes more solute oriented, osmolality increases. So dehydration increases the osmolality. Whereas overhydration or retention of water, in TURP, what happens? Water gets absorbed from the venous channels when they resect the gland and it enters the bloodstream and dilutes the blood. So sodium goes down. So osmolality gets reduced. You understand that? It becomes hypoosmolar. So we try to remove that water by giving diuretic or increase the solute content by giving more sodium. On the contrary, if a patient has vomiting, diarrhea, loses all the water, then the amount of solutes become more and osmolality gets increased. But our body needs a constant maintenance of this osmolality between 280 to 290. So that is done by which part of the brain?
Hypothalamus.
Hypothalamus. Why are you hesitating so much? You are right. Hypothalamus is the part of the brain which has got this function, main important function of maintaining a blood osmolality. and that is done by this antidiuretic hormone. Either allow water to get excreted by the kidney or retain the water depending upon the water content of the blood and plasma. Okay, so ADH has to be secreted where?
Hypothalamus.
Hypothalamus, and that cannot be directly sent to the blood. So it is drained into the posterior pituitary, and from there it is transferred to the blood. Okay, so that is how the posterior pituitary acts. The ADH is not directly secreted by any cells in the pituitary gland of the posterior part of the pituitary gland. It is mainly produced at the hypothalamic level and through the venous channels connecting the brain, that part of brain, and the pituitary, which is called the, again, portal circulation, hypothalamo pituitary portal circulation. So there are two portal circulations in our body. One is in the liver, the other is in the brain. Okay, this connection only brings the ADH to the posterior pituitary, and posterior pituitary plays an important role in the maintenance of osmolality of that. So that is the reason why any pituitary adenoma immediately will not affect the actions of ADH, because it is secreted elsewhere and not in the pituitary directly. Whereas the other hormones, anterior pituitary hormones, are all produced by various types of cells in the anterior pituitary itself. So their action can be either increased or decreased or not affected. Okay, so these are the points that you have to keep in mind. I will just share the PPT for you to see how far these points